Thanks so much, Leah. I think we're going to jump right in. So folks are going to work on, sharing the slides. I think we can pull those up. But just while that's happening, by way of introduction, very wonderful to meet everyone. My name is Welle. My title is I'm the Chief Data Scientist of Allegheny County. Allegheny County is where Pittsburgh is. And today I'm going to present some work that we've been doing over the last year and a half to understand involuntary commitments. In Allegheny County, we have quite a robust data infrastructure where we have digital access to the what are called 302 petitions, but also a host of other data from other folks, from other sources, I should say. So shelters, criminal justice system. And so we're able to understand this problem in a way that a lot of other municipalities aren't. So some of the work I'm going to present today has been published already. It's available on the Allegheny County Analytics website. Some of it is very new work. Likely the working paper will be out in the next month or so. And so I hope everyone feels excited today to get a little bit of a sneak peek of the work we'll be publishing soon. So with that, I think we can probably jump right in and go to the next slide. We've been doing a lot of work on involuntary commitments. I think probably everyone on this call knows, but involuntary commitments happen in each state in the US. They're governed by state law. And so in each state, the process is a little bit different. In Pennsylvania, it's governed by the Mental Health Procedures Act, which is a law from 1976. And the key thing is that you can be detained what's called a 302, which is for Section 302 of the Mental Health Procedures Act, if by the result of a mental illness, you pose a clear and present danger of harm to yourself or to others. So that's where we started. We started with our data analysis journey. So let's go ahead and let's keep moving. Next slide. And the hospitalization process, how does this work? So anyone can call in a 302. So that could be a police officer, it could be friends and family. Friends and family happen to be the most common source, could be a medical treatment team. An individual, when they are petitioned for a 302, are brought into a hospital, an emergency room, where they're evaluated by physician on staff. And that physician on staff, in about a 40-minute interview, makes the determination whether the person is a clear and present danger to themselves or to others. About 80% of those petitions are upheld and people are brought in. Let's click next slide. And then once you're brought into the hospital, you can be held on a 302 warrant, which is a 302 petition, which is up to 5 days. If you are going to be held longer than that on a 303 or 304 extended orders, you need to go in front of the Court of Common Pleas where they make the determination. So next slide. So what is the history of our work here? Well, in 2023, we published something like a 25 page report, really looking through in depth what was happening to people as they were being hospitalized. And there's a lot of detail and nuance here. I encourage you to check out the report if you have time. But when I have to describe it to people in really just a small amount of words, what I say is that we found that involuntary commitments are common. They're much more common than I knew, but that I believe most people know. Outcomes are poor after the involuntary commitment. I think that is a known fact, but I think the numbers might surprise you. And then costs, just dollars and cents costs of this program are very, very high. And so that's kind of our core takeaways. So we're going to step through those one by one. So let's next slide. So in terms of prevalence, nationally, we don't keep good counts on how many people are being committed. There's one sort of landmark paper by Lee and Cohen that basically everyone cites, which gets data from about 20 different American states. And when you do that, you see quite a bit of variance. Some states hospitalize relatively few people. Some states, like Florida, hospitalize quite a few people. But nationally, the number is probably about 350 per 100,000 people. In Allegheny County, where we are, we have about 307 hospitalizations per 100K. And just to give you some frame of reference in case of numbers per 100K isn't intuitive, in the US, there's about 350 incarcerations per 100,000 people in federal, state, and military prisons. So we're we are involuntarily psychiatrically committing about the same number of people that we're putting in prison, which I think most people know is a really, really high number. So this is happening to quite a few people. Let's hit next. And just to give you some other ballpark numbers, in New York City, we're having 70,000 evaluations per year. In California, 120,000 holds are issued in a single year. In Allegheny County, in the data we have going back to 2015, it's 50,000 holds. So it's quite a few individuals being committed. So let's click next slide. So this brings us to our second point about outcomes being poor post-release. What we're looking at here is year 0 is when a critical event occurs. So if you look at that 302 exam line, year 0 on the x-axis is the moment that somebody was brought in for a 302 exam. And then looking out to the right is 1 year, 2 year, 3 years after that exam. And what we see are really shockingly high numbers. There's about a 7% 1-year cohort mortality. It's about 1 in 15 people are going to die within the year. And the 5-year cohort mortality crosses 20%. So 1 in 5 of these folks are going to pass away within 5 years of their 302 exam. And just to give you some ballpark reference, we pulled other populations that we deal with. So the red line here is jail release. Year 0 is the moment you're released from jail. We have when you're enrolled in shelter, if you enroll in SNAP, and also the general population. And the last point I'll make about this slide is that we age and gender adjust all of these lines so that this isn't simply one of these cohorts is older than another. It's actually a measure of risk, and it's one of the first things that we looked at, and it really was a shockingly large number. Let's go to the next slide. We also look at other outcomes. So we look at emergency department visits. This one's criminal charges. So for criminal charges, our 302 population is not our most at-risk population. That happens to be our jail release population. So many people know, but that there's a large problem with recidivism in the United States where folks leaving jail are really likely to come back. But if you look at the second line here, that is our 302 population. And over a year, we're about 10% of these folks are going to get criminal charges. Over 3 years, that's going to be 20%. So across other outcomes other than mortality, criminal charges, emergency departments, we see this population have really consistently elevated poor outcomes. Let's click on the next slide. So the last thing I mentioned was that the costs are high. So we just detailed some of the human costs, which I think you'll note are quite staggering. Even if you only care in a dollars and cents way for some reason, these programs are really quite expensive. So in Allegheny County, we spend somewhere around $300 million on behavioral health spending. So that's mental health and drug and alcohol in our Medicaid programs. So you can see by year here. The second column is crisis spending. These are folks that are in our 302 population, and we just define that as you had been 302'd in the last 2 or 3 years. And what you can see is that $65 million of that $300 million is spent on people who are recently 302'd. And so what we say is that these folks make up about 2% of our Medicaid population, but they're 25% of our spend. So they're hitting our systems in many ways, often very costly ways. But the ways that they're doing that, they're running into sort of crisis spending, inpatient spending. It's not actually resulting in good outcomes for them. So let's click on the next slide. So that's a little bit of the background, right? We did this long report. Again, I encourage you to look through it. There's a lot of detail on what's happening to folks. We break that down by diagnosis. There's really a lot there. So I encourage you to leaf through. But in the last sort of 1 year, we've been pushing on this other question, which is, okay, so folks who are going through these involuntary commitments are ending up with poor outcomes. Is this process of involuntarily committing people, is that helping people or is it not helping people? So we asked this question, does involuntary hospitalization deliver on its mandate? And so let's click the next version. And so we, being a quantitative social scientist, we're going to hear more from Morgan and Awais, who have a lot more experience with these systems. But as sort of a statistician, as a data person, we have to operationalize this. So by being danger to yourself, we look at death by suicide or overdose. and being danger to others, we look at if an individual is going to be charged with a violent crime. And that's how we're going to try to figure out how this program's working. So yeah, let's click the next slide. So how do we do that? There's a classic problem here, which is that if we simply compare the outcomes of people who are committed to the outcomes who are people that are not committed, it may be that the people who are committed have worse outcomes, but those folks might be sort of more acute or have worse symptoms in the first place, right? Because a doctor is making the determination of whether to pull them inpatient. So if you simply compare their outcomes, you'll get a biased result. So what people often do when they want to know if a drug a drug is working, for example, is they'll run a randomized control trial. So in that world, if we could do this, we can't do this, but if we could do this, what would happen is maybe for a year in Allegheny County, if folks came in for a psychiatric commitment, instead of having a doctor decide, we would just flip a coin, right? And half the people would go into inpatient and half the people wouldn't. And because we were doing random assignment here, at that moment, we could just compare the outcomes of people who were brought into the people who weren't. But we can't do that here. In a lot of places, this being probably a prime example, randomized controlled trials are completely unethical. So then the question is, can you never know? Are we sort of doomed to doing these involuntary commitments from now until forever without knowing if this process itself is helping people? And the answer to that's no. There's a number of methods which are called quasi-experimental. They're not fully experimental RCTs, but they are quasi-experimental. And I think if you click next, I'll get some supporting text here. And what you have to do with quasi-experimental work is you have to look for randomness in the system that exists. And so we're going to do something today, and I'm going to talk to you a little bit about it, called instrumental variables analysis. And in finding an instrument, is what we call it, is finding sort of a set of randomness in the system. And the randomness that we're going to use is the fact that when you're brought into the emergency department, you don't choose your doctor. The doctor that does the exam is assigned to you. And we also notice that some doctors are much more likely to uphold your petition than others. So we have 40 doctors in our data set that have upheld 100% of the petitions that they've seen. We have one doctor who's upheld 11% of the petitions. And if you happen to get a very sort of strict doctor, you're much more likely to go in the same way that if you happen to get heads on in the RCT, you're more likely to be committed. So I'll gesture a little bit at the math here, but the core truth is this, that if you go into and you get a very strict doctor, you're more likely to go in, and we can use that doctor randomness in order to try to unpack if your outcomes are indeed worse. So let's click to the next slide and we'll see a little bit how we operationalize this. So we need to find something which is again called an instrument. This is an examiner design. We aren't inventing this, but we are the first people to apply this technique in the involuntary commitment domain. And so the instrument that we're using, again, is physician's proclivity to hospitalize. So we take basically the physician's strictness and we calculate a metric. We do something, I think, one step more complicated than that, which we do something called residualizing on the shift. So it is actually the strictness of the physician relative to another physician that you could have gotten on your shift. But the core truth is that we're just looking at how strict physicians are. So let's click to the next slide. And this is what we end up with. So because we residualize it, it's around mean zero. But what this graph is showing you is sort of different doctors and how many cases that they see. And so 0.2 here, sort of the right side of our graph, means that doctor is about 20 percentage points more likely to uphold than someone else. And you also have doctors who are 20 percentage points less likely to uphold than other folks. So this is quite a bit of variation. So click next on the... And so how does that turn into hospitalization rate? So I've kind of added a line for you here, and I've also added a y-axis. And so if you get a doctor who's pretty strict, so at the 20 percentage point side, you're about 80% likely to go, 85% likely to go in to the inpatient unit. And if you get a doctor who's very not strict, so these are our kind of negative 0.2 doctors, you're much more likely, about 60% likely to go in. And again, this is a sort of randomness that we're using to try to unpack the causal effects here. So let's go next. I'm not going to step through this entirely, other than to say we are applying two-stage least squares with the instrumental variables design. This sort of design, again, we are not inventing. It's been used to look at the impacts of incarceration, where some judges are stricter than others: bail, disability insurance, job retraining, eviction, foster care. Again, the point is sort of anywhere where we would not feel good running a randomized controlled trial, we can look for this randomness. And if we find a good instrument, we can use it to unpack our causal effects. Let's click the next slide. Now, there's one thing which is a huge asterisk and is actually very important for everyone on this call to understand, which is that if you run an RCT, that effect that you get, the causal effect on, let's say, overdose, that's the effect on everyone, because everyone is subject to the coin flip. But mathematically, when you use something like an instrument, the causal effect is only on the people that some doctor might have decided, yes, we're going to uphold you, and some doctor might have decided, no, we're not going to uphold you, right? These are maybe yes, maybe no's. These are, when I present the results in a second, the results are on these maybe yes, maybe no's. Now, we estimate that they make up about 40% of our sample. So it's not kind of 5% of the people here in the middle. It is quite a good number of people. But for the cases where every doctor would have said, hey, let's uphold this case, or every doctor would have said, let's not uphold this case, we're not going to know what the impact on those individuals might be. So I want everyone to kind of squirrel this fact away in their head, that this is kind of for our maybe yes, maybe no individuals. So let's click to the next slide. Now, there are 4 mathematical assumptions for a valid instrument. If you read the paper, which comes out in a month, and I hope everyone here does, what most of it's going to be is going to be arguing about these 4 assumptions, right? We have to, most of the review, our academic peer reviewers are going to care that we've met these 4 assumptions, because if you meet these 4 assumptions, mathematically, you can then say, hey, this is a causal estimate of my program. So I'm going to walk them through them just very quickly with you, and then we'll do the results. I always kind of save the results at the end because nobody wants to listen to this if you already know what I'm going to say. So the first is relevance. So the instrument has to be predictive of the treatment. Again, our instrument is how strict your doctor is. So getting a stricter doctor should mean that you're more likely to have an upheld petition. And that's true. Fortunately, this is empirically verifiable. You can run some stats. So I showed that graph with the blue line before. That's how you know that your instrument's relevant. The folks that are getting the stricter doctors are actually being upheld more often. So we feel pretty good about that one. Let's click to the next one. The second is what's called exogeneity, which is the instrument shouldn't be correlated with any of the covariates. So imagine the strict doctors see all younger patients, or the strict doctors see patients that have bipolar. In that world, your doctor isn't actually random. It's correlated with your covariates, and our estimates wouldn't be valid. Now, because of how ERs work, where you basically get seen in rank order, we feel pretty good about this one. And we can also check this against all of people's diagnoses, their shelter usage, and we don't see any correlations there. We actually pass a pretty strict check. So for exogeneity, we feel pretty good as well. So let's click to the next one. The third of the 4th assumption is called the exclusion restriction. The exclusion restriction means that your instrument shouldn't be correlated with your outcome except through the decision for treatment. So this would fail if, for example, you saw a doctor in the emergency room, and then that same doctor treated you on the inpatient ward. That's not how the system works. The emergency department doctor only makes the call on whether you're upheld or not, and then a different set of doctors in the inpatient units treats you. This one isn't empirically verifiable. There's no statistics you can do, but we feel pretty good about this because of the structure of the program. Let's click to the last one. And monotonicity. So the instrument has to affect everyone in the same way. So for example, getting a stricter doctor means you're less likely to get upheld if you're young or if you're old. that would break monotonicity. And we can check this for all the variables in our data set, and we see what you would expect, that stricter doctors uphold more likely for each of our individual subgroups. Okay, that's the boring stuff. Let's start talking about some of the results. So this is what's called an ordinary least squares regression. We're going to compare the results of people who are upheld against people who weren't. Now, this is not a causal estimate. The folks who are upheld could be sicker on average. And indeed, that's what you see, that the folks who are hospitalized are upheld more often than the other ones. It's not statistically, or sorry, die by suicide or overdose more often than folks who aren't. So that's kind of our baseline comparison. So what happens if we start trying to apply some of our causal methods? Let's go to the next slide. The first thing that you can do is what's called a reduced form, which is you can just look along the instrument. That's, again, the x-axis. And now the blue line is comparing, this is how prevalent death by suicide or overdose is in 3 months after the commitment. And what you can see is that folks at the right tail, folks that get the stricter doctors, are dying more often by suicide or overdose. So it's kind of our first check. And then our full results are the next slide, which is, this is months after evaluation on the x-axis. And it's our estimate, again, using this instrument and this two-stage least squared approach of what death by suicide or overdose look like. And what you see is we see an increase, and we see that maintains over 6 months after the evaluation. So I'm going to do our next result, which is violent crime, danger to others, and then I'll try to unpack why we think this might be the case. So this is our ordinary least squared regression. Again, you see basically no difference. So the people going into inpatient are committing violent crime at about the same rate as the folks who aren't. And click to the next slide, we'll have the reduced form. We'll see again that folks that get stricter physicians are being charged more often with violent crime after they're released. And then lastly, the next slide will be our full results, which is what our estimate says for months after evaluation, changing from that gray line for our control to our treated group. We see a statistically significant increase in violent charges. So let's click to the next slide, and then I'll pass the mic pretty soon. There's a lot of potential mechanisms here. I think that Awais and Morgan are sort of prepared to talk in a lot more detail, with a lot more experience on what might be going on here. But we have a number of theories around substance tolerance, disruptions, obviously, to family, employment, housing, and outpatient care. In the paper that we're publishing, we're also presenting evidence that folks are significantly likely to lose their jobs. So, 60% of people are going to be held for 5 days, 40% of people are going to be held for longer than 5 days, which means 25 days or more. And that, for lots of people, will cause them to lose their employment. And indeed, with the same setup, we see that that's true in the data. We also see folks going to our shelters more often. And so as I've tried to come to terms with some of this results, and again, understand the mechanisms, is that an involuntary commitment is an incredibly disruptive process. It's going to, it's obviously not voluntary. It's an unpleasant experience to have your autonomy overridden. And so there are concrete costs that go along with this, that it's going to, it might damage relationships with your friends or family or your treatment teams. And the only people who might net benefit are people who were really helping in the short term, people that really, would, benefit from the incapacitation effect of like the strong danger to self or others. And what the results that we presented here today say that for the people that we're sort of unsure about, which is a large number of people, it's about 40% of our people, it seems that we are having, on average, a net negative effect. So can you click the next slide? I believe that's my last one. So yeah, some takeaways. Again, just to start with the top, these commitments are really common. It's happening to a lot of people. The outcomes are after release are poor. And for these folks that one group might hospitalize and one group might not, it doesn't seem to serve its statutory purpose. We actually see an increase in danger to self and danger to others. Now, you only can get so far with the data. It's never going to tell the whole picture. So there's a lot more work to do on identifying, understanding the mechanisms. But we believe this is like a good jumping off point. And I think maybe with that as a transition, I can, pass the mic over to Morgan, who will be talking next.
Great. Thank you, Pim, for your presentation and your incredible work. I agree with Rob in the comments that this is groundbreaking. I'm going to try to share my slides, and if it does not work, I'm going to ask for assistance. So I have these as a PDF right now. We'll see if it works. All right. Can folks see these slides all right? So
yes, we can see them.
All right. So you might have to tolerate seeing some of the preview over here, but it's the best we can do right now. Okay. So I'm going to just sort of follow on to this conversation about potential mechanisms of harm. As an introduction, my name is Morgan Shields. I'm an assistant professor at WashU in St. Louis. I'm currently in our School of Social Work, but I'm going to be transitioning to our new School of Public Health soon. So I just put that title there for now. Okay. So first, I'm just going to give some general background. So the analysis that Dr. Welle just presented really is groundbreaking. So scholars have been attempting to isolate the effect of inpatient psychiatry for decades, since about the 1950s. And there is this ethical issue where you can't easily randomize a person. And so what some have done prospectively is they have utilized randomized control trials to hospitalize people in inpatient versus some sort of alternative. So the comparison then is not nothing, that they are getting something, but and for those studies, they typically do randomize people, quote unquote, on the margins. So it is similar to using an instrumental variable in some ways, in that typically the people eligible to be randomized are not people who would be considered to be, have the most, quote unquote, severe symptoms. And so, but there have been studies since the 1950s, and they have failed to produce any evidence that inpatient psychiatry is more beneficial than these alternative settings like intensive outpatient or even peer respites. And in fact, on some outcomes, these alternatives produce better outcomes, specifically when it comes to social functioning, which makes sense, right? Because with inpatient psych, you're taking someone outside of their community and disrupting that. We also know that risk for suicide, and these are international estimates, is extremely high. It's the highest risk period for people. It's about 258 times the general rate within the first week of discharge, and about 180 times within the first month. Of course, the limitation has always been, well, we don't have the counterfactual. We don't know what the risk would have been without inpatient psych. And there's this selection issue where you have people who are already at high risk being selected into the hospital. And only about 50% of people, this is in the United States nationally, have a 30-day follow-up visit after discharge. And that rate is lower for people with psychosis who are men, and who are younger age or have a substance use disorder. So that's a pretty low rate of follow-up and engagement in post-discharge care. And then there's some evidence for iatrogenic harm. And a lot of this evidence really, I think people in the comments were talking about this, really is people's lived experience in their testimony. And there has not been a lot of really rigorous quantitative research. And so this study really is quite the contribution. Okay, so I'm going to map out some potential mechanisms. Dr. Welle, described some, and I'm going to focus in on sort of my specialty area that I think a lot about, which is patient experience. But I'll try to map out some of these. So first, there's before the hospital, right? And before a crisis. I mean, some of this is sort of co-occurring, right? But people may, and just to say also, this is just in general. So there's obviously individual variation, but before people actually experience a mental health crisis, there may be other types of disruption in their life, like job loss, housing loss, relationship fracture, etc. And then these disruptions lead to a crisis, some sort of psychic distress, as well as the social response to that. So we have some work where we're developing a measure of trust in crisis mental health services. And as part of that work, we've done focus groups with people who have lived experience and loved ones, as well as providers. And what's interesting is when we ask people, how would you define a crisis, is that for some folks, it is very much defined as their internal states, their mental health status. But for others, actually, the crisis is defined by external observers. And in fact, for some, the crisis is sort of created, like the response to whatever they're experiencing then becomes the crisis, right? And then that, in totality can lead to more disruption, right? So if a person is having a mental health crisis, social response might also include, a disciplinary action at work, et cetera. So that's all before the hospital. And then you have the hospital, and here I'm calling this involuntary hospitalization because that's sort of the focus of this study. But you could just delete the involuntary, right? Because I think these categories of involuntary and voluntary are actually quite fuzzy for people who actually have lived experience and what people don't always know if they're voluntary or involuntary, right? Okay, there's like the soft coercion happening. So the hospital is an intervention. And a lot of discourse has focused on what's the effect of hospitalization or involuntary hospitalization. But the reality is that it's not a monolith. So people who are hospitalized are not experiencing the same things, right? There's this black box of stuff that's happening to people that can vary and that likely matters. So if what actually happened to people when they were hospitalized didn't matter, then actually why do these hospitals exist, right? They exist because we think that there's something happening in them that might be beneficial. And so, for example, there's medications. So when we're thinking about the category of disruption, the primary lever that is at the disposal of the hospital is changing medications. So people get taken off meds, they get put on meds, there's this disruption. And most people, unless we're talking about people who are civilly committed or the forensic population, are hospitalized for short duration of time, relatively speaking. Not a long time to be able to observe how they're responding to the medications. And in an ideal situation, they would have robust follow-up care and they would be observed in the community, et cetera. But anyway, but there's this change to medications. Then there's also the interpersonal treatment that people have, which in my research and in international scholarship on patient experience and inpatient psych, this tends to be what people point to as the most important aspect of their care experience, is how they were treated by the frontline staff specifically. And in fact, if their treating physician is sort of doesn't really engage in shared decision making and is not that great, that actually matters less than how the frontline staff treat them, because people are exposed mostly to the frontline staff and to other patients. And then you have human rights and just in general, you could think about the extent to which a person might experience a restraint episode or to witness these types of events, the general structure of the environment, the culture of humanity or the lack of humanity within an environment potentially varies across organizations. And so the actual hospitalization itself, because it removes people from the community and because it is a stigmatizing sort of event, then potentially directly create some of these negative outcomes like Dr. Welle was describing with losing your job. If you just disappear for a month, that's going to be really hard to justify why you should keep your job, especially low wage jobs. So I think if myself as an academic, if I disappeared for a month, no one would probably notice. Maybe some people I have meetings with, right? But I could probably come back and it would be okay. But people who are really vulnerable are probably more susceptible to losing their job. Housing loss, especially if you're then not able to make your rent, fractured relationships, et cetera. And also people are probably also still coping with what happened before the hospital as well. And then you have this, which may be directly impacted by what's inside the black box, sort of the medication changes, the relationships, et cetera, that have direct impact on mental health, for better or worse, right? So if quality of care is good, potentially, that maybe can improve mental health. But To the extent that people experience negative care and really dehumanizing care, you can imagine how that could lead to PTSD and worsening mental health. And then you have this pathway of reduced trust. Because of one's experience, they have made potentially reduced or increased, it depends on the experience, trust in mental health care providers and willingness to engage in care, which of course can impact mental health and other outcomes. The one thing I don't have on here is with regard to substance use. I think Dr. Welle mentioned this, but the change in tolerance. Most even residential treatment facilities who are supposed to be specialized in treating substance use disorders in the United States do not provide medications for people. And so the risk there is when someone withdraws, their tolerance is reduced. Then if they use at discharge, they're at much higher risk of overdose. And we have no evidence that inpatient psych is doing a better job than specialty substance use disorders in that regard. So I'm going to just share some data on the black box, and I'll try to be quick because I'm aware of the time. But first, I'm going to focus on dehumanizing experiences. And this is an image that was created by Phoebe Sparrow Wagner with permission. And I think it's a pretty powerful image. And you can see that there's someone sort of watching in the background. I appreciate that because sometimes these events can be traumatizing for observers, not just the person experiencing it. The other thing I want to point out is this is a woman and there are 6 people holding her down, right? And she's not strapped down. So it's looking like she's about to receive a chemical restraint. And in conversations I've had with clinicians, they have said to me, well, chemical restraint isn't that traumatizing. And in that it's evidence-based even, right? Because it's a way to prevent physical restraint. And of course, yes, if your outcome is to prevent physical restraint, then of course, I guess it's evidence-based. But this notion that receiving a chemical restraint is not potentially traumatizing to a person, I think is rubbish. And I'm someone who has experienced chemical restraint myself, really similar fashion to this, and have coped with PTSD as a result. So I'm going to share a couple of quotes. I will never go back to a mental health facility ever again, even if it means I end up killing myself instead. There is zero trust there, and it felt like I was in prison. So for an intervention that is supposed to be helping people and improve their mental health, this is the opposite of what we would hope would happen, right? There's the cascading effects of reduced trust and willingness to engage in care that's sort of expressed here. I watched techs, these are frontline staff, bash patients' heads into the ground. They literally ignored the one woman who repeatedly kept talking about how police were going to come kill her because her brother was the Messiah and past child sexual abuse. And for me, I wasn't allowed to have underwear or clothing for 3 days. So 2 things I just want to point out with this is that this is a patient population that has high prevalence of trauma and sexual violence history. And it is not uncommon for people to not have access to underwear or clothing, and in fact, to be strip searched, which can be not only dehumanizing, but really triggering for people who have a history of abuse. And the other thing I want to point out here is this sort of ignoring of the staff, ignoring someone who might be in psychosis, right? This, I think, really sort of exemplifies an attitude towards that I find to be prevalent in the system towards people with psychosis, that they're not fully human. And if they're not fully human, then you don't need to treat them with dignity and respect. And this sort of attitude is used to justify grabbing people and restraining them, not answering their questions. And so if you can imagine being in a state of terror, which a lot of people in psychosis are really scared, right? Here, this is someone who thought that they were going to be killed. They're scared. So just intuitively, I'm not a clinician, I'm someone with lived experience, right, who has sort of experienced this. But also just intuitively, if someone is scared and they think you're about to kill them, I think the worst thing you can do is to really confirm their fears that you're not on their team, right? And then these are complaints from the Department of Mental Health in the state of Massachusetts across 11 years, 2008 to 2018. These are regulatory complaints. And I'm going to highlight a few of these. So across the 11 years, which is about 70 hospitals, There were over 2,000 complaints related to human rights violations, physical abuse, over 1,000 related to verbal abuse, 945 complaints related to sexual abuse, 576 related to medical legal death. These are deaths that required investigation by the state regulator. And it does capture any known deaths post-discharge, but really only if it sort of made its way back to the state regulator. And this should be viewed as the tip of the iceberg, because an event has to happen. Someone then needs to report it. They need to follow through with it instead of withdrawing their complaint. It can be quite tedious and scary to follow through with an investigation. And so really this is the tip of the iceberg. And the other thing I'll point out is abuse is a never event. It's not justifiable. There's no clinical justification for it. And this is different than, for example, restraint and seclusion. So an argument when it comes to restraint and seclusion is we can never get to zero restraint. And hospital A has higher restraint than hospital B, but maybe that's because hospital A treats quote unquote sicker patients. This is this argument. Well, that argument doesn't really apply to abuse because it should never happen. And some people have this view on the use of restraint and seclusion, but you can see how there's more room for debate there. And then lastly, what I'll share is we've done a few national surveys now, but this is from a couple of years ago. We did a national survey of patient experience of inpatient psychiatry, both voluntary and involuntary folks. And we were interested in understanding the relationship between the experience of care and whether or not it was patient-centered and outcomes of reduced trust in mental health providers, reduced willingness to disclose distressing thoughts, to engage in care, and 30-day follow-up visits. And so that's what this slide is showing is it's a measure of patient-centered care divided into quartiles. So the dark red is the bottom 25 percentile, so they have the worst quality of care. And the teal or the blue is the top 25 percentile. So first of all, there was variation. So some people are having positive experiences. So that's the first point. But then you can see that there's a strong monotonic relationship with these outcomes, which are negative. So you want the bar to be lower. So for example, there was about a 70% probability that people in the bottom 25 percentile reported that their experience directly reduced their trust in mental health providers. And that's in comparison to about a 35% probability for those in the top 25 percentile. And then the biggest effect is related to willingness to go to the hospital on a voluntary basis, which makes sense because that's sort of the most proximal setting. And then this next slide is actually looking at positive outcomes. So having a bad experience might increase odds of negative outcomes, but having a positive experience might increase odds of positive outcomes, right? So we wanted to see if people in the top 25 percentile were more likely to have a 30-day follow-up visit, and they were. The effect's not as strong as some of these other ones. And then people in the top 25 percentile also much more likely to report that their hospitalization actually increased their trust in mental health providers and sort of increased their willingness to go to the hospital on a voluntary basis. I'll skip over this just in the interest of time, but just to say that we asked the same questions, but using a measure of institutional betrayal, and which is sort of a mirror of patient-centered care. They are distinct constructs. But it was in a similar fashion associated with these outcomes. And there was no interaction with voluntary status, meaning these relationships held even if someone was hospitalized on an involuntary basis versus voluntary. And what I'll say there is there's literature from the UK actually that suggests that patient-centered care and the patient experience is actually most consequential for people hospitalized on an involuntary basis. So rather than it not making a difference at all, that actually it has the largest effect. So it sort of depends on the research design and how you're measuring these things, but we didn't find a difference at all. So this is just, these are the potential mechanisms. And my takeaways here are that there are an array of potential mechanisms. I just focused on the experience and the black box. I didn't focus on, I mentioned the disruption in the community and one's life, but I didn't focus on those. And so just on a conceptual basis, if we were to map out all of these risks, they're substantial. And now we have more robust empirical evidence, thanks to Dr. Welle and his team. And there's very little convincing evidence that inpatient psychiatry is beneficial. And so this does raise questions about what we're doing with regard to involuntary hospitalizations and whether or not it's ethical. Right. It's sort of the only time when you can force a person to be hospitalized or to be incarcerated against their will when they haven't committed a crime. And so that should only happen if we are sure that this is a positive thing. And the evidence is not supportive of that notion. And then the final points I'll make is inpatient psych is also not a monolith. And so it is important that when we have these conversations that we don't treat it as though it's this one singular thing that's happening. And what happens inside of the hospital is also important. And there are variations in patient experience. So I think focusing on patient rights and the utility of involuntary hospitalization is important, especially from a policy perspective. But it's also important to, keep awareness of what's actually the experience of care, and those principles sort of at the center of this discussion is my opinion anyways. So thank you for your time. I'll stop sharing.
Hello, good afternoon, everyone. I'm pulling up the slides. Okay, wonderful. So, great to be speaking as part of this panel. I kind of concur with the sentiment previously expressed. Dr. Welle's research, really wonderful, very groundbreaking. And this was an area where we desperately needed more rigorous kind of quantitative analysis, and Dr. Welle's team has done this wonderful work. So I'm really glad that it will be published soon. And in fact, I've been eagerly awaiting its publication since our ISPS panel, and I think it's been a little delayed, but hopefully in the near future. And so, as when this panel was initially being designed and conducted for the ISPS meeting, I was thinking about how I can meaningfully add to this conversation and how I can contribute from my perspective as a clinician who has worked in psychiatric hospitals, who still works in psychiatric hospitals, who has involuntary admitted and committed patients, and what are some of the dynamics that I have observed around that, and what can be done to shift the practice, and as well as our thinking around these things in a more positive direction. So over the next 15 to 20 minutes, I'll be talking about kind of my perspective as a clinician on institutional dynamics around involuntary psychiatric hospitalization. No relevant financial conflicts of interest from my side. As many of you might know, I write a Substack newsletter called Psychiatry at the Margins, exploring kind of several different types of philosophical, scientific, and other critical debates in psychiatry. I edited a book from Oxford University Press called Conversations in Critical Psychiatry, which is an edited collection of interviews, came out a few months back. And I'm a senior editor for the Journal of Philosophy, Psychiatry, and Psychology. This is the book that I was just mentioning, if anyone is interested. So here's my central takeaway from Dr. Welle's paper as a clinician. If I had to distill it in one sentence as to what the lesson is, for me, this is the takeaway. It is that in situations where a person can be conceivably discharged rather than involuntarily admitted for psychiatric reasons, it is better to discharge. So we're working, as Dr. Welle emphasized as well, we're working in this gray zone where there is expected or reasonable or actual disagreement among clinicians, where one clinician would discharge, whereas another would admit. We're not really quite talking about situations where there is unanimous decision making, where all clinicians would agree that a person needs admission, or all clinicians would agree that they need discharge. We're in this middle zone, and in this middle zone, it is better to discharge. Now, this is something that I had personally believed as well throughout my career. I had mostly believed it for ethical reasons and for reasons of human rights, as a respect for a person's autonomy, respect for their decision making. But I think now we have data supporting that this also makes sense in terms of long-term outcomes. And by long-term here, we're looking at 3 months to 6 months kind of time frame. Is that if we want to optimize and improve a person's safety in terms of suicide risk, overdose risk, that it is better to discharge. And I think once these findings are published, this would really push the system. Hopefully, I hope to reevaluate processes around this issue. Now, the debate around involuntary psychiatric commitment and involuntary treatment gets messy pretty quickly, and there's a tendency often in public discussions to conflate different dimensions and aspects of it. So this slide just kind of outlines different, distinct elements of this debate, and that we should keep in mind that these are relatively separate things. So the first element is involuntary psychiatric care ever justified? And this is an abstract philosophical and ethical question about the necessity of, are there situations where, for example, we have to override a person's expressed wishes, or we have to confine them, for their immediate safety, etc. Now, a lot of the public debate tends to focus on this question, which I think is a mistake, because this is also where I think the case is the weakest, because when we are dealing with severe instances of psychiatric disability, severe instances of risk, it's hard to say that there are no cases at all where this is ever justified. So when we make this debate abstract and absolute, I think we run into problems. But then there are other questions that I think can be more meaningfully and productively addressed. How can involuntary psychiatric care be prevented as much as possible? If we shift the emphasis on preventing it, there's all of us can think of things we can do practically, systemic, in the community that will reduce reliance on that. And I'll talk about some of them. Then we can talk about alternatives, that if we have a situation where someone is severely incapacitated due to psychiatric problems or psychological problems, or let's say they're at significant risk for suicide or violence, what can we do instead of sending them to an inpatient psychiatric unit? Instead of that person, let's say, going back home to their ordinary life or going to jail as an alternative in some cases, what clinical alternatives do we have to involuntary psychiatric care? And I'll talk about some of them as well. And then finally, how can involuntary psychiatric care be made more therapeutic or humane? That is, how can the harms of involuntary hospitalization that we are seeing research can outline, how can they be mitigated? And this is a question about the experience of care, and how can we improve that experience of care in a manner that it is not producing the negative outcomes that we are seeing. Now, I want to go back to this question of, why do some clinicians choose to admit when their colleagues would discharge? And kind of my view is that a lot depends on perception of risk and how different clinicians choose to manage or mitigate that risk. And here we have to keep in mind that suicide and violence risk are nebulous. It's not something concrete that we can reliably measure. It's a vague assessment that every clinician is kind of doing. We have some loose criteria or loose kind of indicators that we use, but it is far from robust or reliable. And then another thing is that imminent risk is different from chronic risk. So we can talk about, for example, risk of a person attempting suicide or dying by suicide, over the next couple of hours, over the next day, over the next few days, versus we can talk about the risk of suicide, overdose, violence over the next 3 months, over the next 6 months, over the next 1 year. And so the time frames are also different. For a lot of the times in emergency room settings or other psychiatric emergency settings, clinicians are focusing on imminent risk. They're often thinking of what needs to happen to ensure this person's safety over the next couple of hours, over the next couple of days. they're not really the idea of what their risk 3 months down the road is going to be is not something on their mind. And that also distorts that decision making in interesting and sometimes negative ways. And on top of that, we have no method of risk assessment that comes anywhere close to reasonable accuracy. So no matter what kind of assessment scale we use for suicide risk, violence risk, or no matter how we clinically assess it, even if we don't use an instrument, the predictive power of that assessment is very low. And this has been demonstrated again and again and again in numerous research studies and meta-analysis. Another important thing to keep in mind is that for a lot of people, when it comes to suicide risk and violence risk, the true purpose of involuntary hospitalization, from the clinician side and hospital side, is risk management and liability control rather than meaningful risk reduction. So a lot of people who are getting admitted involuntarily, they're not being admitted so that their risk is meaningfully addressed and meaningfully reduced, but rather they're being admitted so that the hospital can demonstrate that, we took some stress, we took some steps to manage this risk, and they take steps to minimize the liability they have in terms of malpractice or in terms of other legal violations. But so the goal is often along the lines of risk management and liability control rather than hey, we genuinely want to help this person and we genuinely want to increase a 6-month outcome for them in terms of their quality of life, etc. So all of those things contribute to kind of this disagreement, this realm of disagreements among clinicians. I also feel that discussions of involuntary hospitalization tend to overemphasize suicide risk and violence risk. This is sometimes kind of very prominently mentioned in legal statutes, such as, for example, the Pittsburgh legislation kind of emphasizes suicide and violence risk. From my perspective as a clinician, the situations which truly merit involuntary psychiatric care from a clinical or therapeutic standpoint tend to be situations of severe psychiatric disability, where the person is unable to care for themselves or their judgment and behavior is so altered that their family can no longer care for them or keep them safe. So these are situations where we're not just trying to assess risk, manage liability, but there's a desperate need for some kind of clinical response to the individual. And in these kind of situations, they are a subset of the overall population that gets involuntarily committed. And different statutes, legal statutes, give different emphasis to it. In Ohio, for example, this is one of the core criteria, psychiatric disability, in California as well. But the emphasis that different statutes give to it can vary. One idea that has been helpful for me in conceptualizing the state of affairs is the writer Nassim Nicholas Taleb's idea of skin in the game. And he writes in his 2018 book, he writes, the legal system and regulatory measures are likely to put the skin of the doctor in the wrong game. Now, he's not talking in the context of psychiatry or in the context of involuntary commitment. He's talking generally about all of medicine. He writes, a doctor is pushed by the system to transfer risk from himself to you, and from the present into the future, and from the immediate future into a more distant future. So let me explain what this kind of means and how this looks like, in the context of this debate. So physicians and hospitals are under pressure from two general sources. There is one, the risk of lawsuits and complaints to the medical boards. And then there is scrutiny from regulatory and accrediting agencies, from Joint Commission, from CMS. So if any kind of serious incidents that take place in the hospital, if there's a suicide death in the hospital or immediately post-discharge, if there's serious incidents of violence, then Joint Commission and CMS are kind of really interested in reviewing those, and the hospital gets under scrutiny. So hospitals face liability scrutiny if a patient they didn't admit dies by suicide. Some of this is perceived liability, but but it's kind of it's there, it's in their mind. So if a patient they didn't admit dies by suicide or commits violence or experiences some other tragedy, there's liability if a patient dies under their care or elopes from the hospital. There's liability if a patient dies shortly after discharge or if they get readmitted shortly after discharge. But there's no liability or penalty if a person's long-term risk of suicide or violence increases, or they die, for example, they die or end in jail 3 months later or 6 months later, or if their admission is very traumatic for them, or if they lose their jobs, the patients lose their job, or if they lose their trust in the medical system. And all of those things happen frequently enough, when due to patients being admitted in the inpatient setting. But no one is monitoring them. No one really cares for them. No one is assessing them in any kind of systematic way. And even when they are, it has no impact on shifting the priorities and preferences of clinicians and the system. So considerations of liability in this distorted manner, where we are paying attention to a subset of things, but we're really kind of ignoring and minimize these long-term outcomes. They influence both decisions to involuntarily admit people and the experience of care on the inpatient unit. Psychiatric hospitals are currently optimized around considerations of risk and liability and bureaucratic needs of accrediting institutions. This is reflected in the architecture, in the furniture, layout, admission processes, nursing monitoring protocols, patient privileges. And for many years, I worked in the state psychiatric hospital system in Ohio. And it was apparent to me that every aspect of the hospital was designed and kind of to manage risk and manage liability. And then therapeutic concerns were a secondary consideration for them. And every day I would wonder, what would it look like if psychiatric hospitals were optimized for the therapeutic benefit and psychological well-being of patients? If they were designed to ensure autonomy and comfort and dignity and social connection for patients, and they would look very different from what hospitals look like right now. So we have, so what to do about this? How to change, these practices around risk and liability? One thing to do is change incentives for hospitals and physicians. That is, emphasize more patient-centered outcomes and hold clinicians and hospitals accountable for them. And I think that the research that Dr. Welle and his group is doing and Dr. Morgan's group has been doing is really important, because it highlights the importance of it. It highlights the dangers of overlooking these metrics, and it starts the process of holding the system accountable and responsible. And then a second thing is that we can change the broader culture of risk and liability that we exist in, especially in America, to some extent in the UK as well, other parts. There are therapeutic communities that have demonstrated a very different relationship with risk and liability. I think the Trieste model in Italy exemplifies what happens if we make risk and liability considerations, secondary or tertiary, and we focus on social connection and therapeutic support, and we come up with a very different kind of culture of care. But both are easier said than done, because there are powerful forces at play, keeping this going. There's tremendous inertia in the system. Clinicians, in many ways, I'm talking about frontline clinicians, not the administrators or heads of national institutes. Clinicians are poorly equipped to challenge the status quo. They are trained to be risk averse. They are trained to follow conservative understanding of the laws. They're trained to be paternalistic. And we have seen this, for example, in the realm of reproductive medicine, with laws restricting abortion and other reproductive rights in many states in the US. And clinicians have fallen in line, and in fact, they have been proactive in implementing those restrictive legislative efforts. Physicians also get defensive easily when the system is critiqued. And the frontline clinicians, in many ways, are also not the ones with the power to change systems and policies. I have worked on many inpatient units, and I never had the option to even modify any of the kind of policies that the inpatient unit was implementing, because they were all decided by some administrator, in discussions with legal aspects and other things. So in the interest of time, I'm just going to quickly go through this. But what will prevent involuntary hospitalization? Expanding community services, accessible outpatient care, housing, peer support. I think everyone in this audience already knows and understands these things. We need meaningful alternatives to involuntary care, expanding truly voluntary inpatient care and open door units, crisis stabilization units, crisis houses, peer respite centers, and innovative models like home hospitalization, which Canada has experimented with. And we also need evidence to support these alternatives and show their superiority. And at least in the U.S. context, we need these alternatives to take on the liability that we currently expect emergency rooms and psychiatric units to take on because of the whole emphasis that risk and liability has in American culture. So with that, I'll stop the formal part of the presentation. It's my email address and the link to the newsletter. And I think we can open up for questions and then comments for the audience for all three of us.
Great. Here we are. So thank you, everybody who presented today. I know we've had a really great chat discussions going on here. I really appreciate all your important research and the findings that you had. I really appreciate the deep sharing that we've had. And I can see my own story and the stories of people I've worked with represented again and again through the presentations and the chat. I just really want us to underline the importance of today's discussion before we go into the Q&A. As some of you referenced and has been talked about a lot in the chat, this is a critical conversation to this moment in time because of the increased levels of coercion that are happening across the mental health system in the States. We see it in California care courts, what's happening in New York City, and the proposed increase of involuntary treatment in Oregon. So it's a really troubling trend and a political battlefield. It's a minefield. And all the research that you've presented today isn't telling us anything we didn't already know. I mean, it's groundbreaking, but we knew that this was true from our own stories, that coercion hurts and it breaks the trust of people who are exposed to it. And I'm glad we're able now to have some data to back up this perspective and able to help people to think more critically at what happens to people after they've been hospitalized. So hopefully this discussion leads to more advocacy and organization around promoting humane holistic alternatives. And I like to think at ISPS-US, we're doing our best to promote those alternatives. So if you've enjoyed today's discussion, I encourage you to check out what we're doing, check out our conference coming in November and be part of this movement. So I'm going to do my best to keep up with the questions. I did keep a note of some that came in already. And while you're chatting and answering, I'll just go back and try and find a few more. So the first question came in while Pim was talking. So the question was, do you have any idea of how big the effect of job or even housing loss impacts the results?
Yeah, absolutely. So I think what the question is there is, is the mechanism folks are losing their jobs, and that is a distressing thing and results in some of the downstream effects. I think with what we've done so far, it's going to be really hard to untangle what's causing what. Like we can see bad outcomes are moving together, and that's a really important thing to see, but you never quite get as far down the chain of causation as you'd like to get. I will highlight that the employment effects that we're finding are pretty large. There's something like a 20% reduction in income on average. So I think that, anyone on this call could definitely experience, say what their experience would be with a 20% reduction in income. And that's on average. Some folks are losing their employment entirely. And so what we know is that is, likely a mechanism or something that's contributing towards the worst outcomes. But untangling the whole causal chain is going to be pretty hard. So I hope that's helpful. Thank you.
I mean, it's pretty impressive what you've managed to do with the data already, but yes, that must be a challenge. Okay, the next question came in while Morgan was talking, but I think it's something that maybe everyone could contribute to if you have something to say. So the question was, I wonder if major care or treatment gaps in the mental health system before crisis or involuntary commitment could have been examined as a key disruptive precipitator of crisis.
Yes, and I actually think that's a question that's a really good fit for the type of data that Dr. Welle used, because you can observe in claims data contact with the system, at least for those who are continuously enrolled in health insurance. So I know that there's been some work to look at the role of post-discharge engagement in care. And there's some evidence that if we can get people to engage in care within a week of discharge, then that can prevent suicide and some of these negative outcomes, but suicide in particular. But I'm not sure about the period before hospitalization. I'm not sure if others have comments.
Yeah, just to piggyback on that, we've also put most of our attention in the period after the commitment. And what you see is that folks are really not engaging with low levels of care after they're committed, much lower rates than folks who are coming out of voluntary inpatient, for example. And the numbers are really way too low. So among our Medicaid recipients, I believe something like 30% of them are going to outpatient care within 90 days. It's not enough, right? If you go through an involuntary inpatient care, you should be getting some form of aftercare there. And so and then the other piece on the pre-piece, I feel like when you come to the data, you're often wanting a clean story, but because we are committing something like 4,000 to 5,000 people a year, different people have different stories here, right? Some folks are going to be using a lot of care before they're committed, calling into crisis lines. We see a lot of calls to crisis lines before the commitment happens. Some folks aren't going to be using very much at all. And there's just going to be a little bit of everything because this population is so large.
Yeah, I mean, I think that, ironically, sort of folks who are actually engaged in care, there's greater opportunity for them to get referred or have cops called on them because they've disclosed or they are presenting in a way to people who are mandated reporters, et cetera, than folks who are just not engaged. I think that they have to reach a certain level of, social disruption for external observers to step in. It's a much higher bar.
Yeah, I think it seems to me that there are many different pathways, and in the days and weeks preceding to the inpatient admission, for some people who are completely disengaged with, mental health services, for them, as Dr. Shields mentioned, certain amounts of social disruption, other disabilities, impairment, etc., come up, which, if they were receiving good, outpatient care, could have been prevented. But on the other side, there are folks who are engaged in outpatient mental health treatment, and they get admitted because of what happens during that outpatient treatment. So, for example, let's say a therapist or a psychiatrist overreacts to a person's, disclosure of suicidality, or medication changes are made that are, let's say, not done in a collaborative manner and lead to decompensation, or medication changes are made and a person experiences, side effect, let's say akathisia or other things. So I think there is this kind of, we're in this complicated situation where some people are getting admitted because of not enough outpatient care, and some people are getting admitted because of bad or poor outpatient care. And I think this has been generally neglected by research, so it's hard to quantify, but it would be good thing to look at in the future.
Thank you for your responses. We had a few comments and questions on the notion of weaponizing the system. So how perhaps an abusive family member or somebody seeking to exert control over another person could use the system to involuntarily commit somebody. And I suppose this is becoming more of a concern with reduced standards for involuntary commitment, where it's based upon a community member's concerns rather than an actual documented risk. So I wondered if you had any thoughts or comments on this potential issue of weaponization.
Yeah, I have a few things to say, which are that, that I think that's a really large concern. One thing that came up actually, so when I started doing this work, I was doing a lot of interviews with doctors because unlike Dr. Shields and Dr. Aftab, I have less experience with inpatient units, so trying to understand what was going on. And one thing I was alerted to is just the 201 process. And so in Pennsylvania, that's the voluntary admission process. So if you're brought in for a 302, you can decide to go in on a 201. And what's interesting about that is that most 201s are among people less than 18 years old. And the reason for that is that the parents can sign the 201 forms. So it's considered a voluntary commitment, but it's the parents who are sort of consenting to that process. And so 201s are actually pretty rare among our over 18 population, but they happen quite a lot for younger folks. And then, there's always the case when you're having one of these 302 exams that, the doctor is going to have to decide who to believe in many circumstances. And we had doctors talk to us and reflect on sort of what sort of patients do they believe. So sometimes there's a 30-year-old man and he seems relatively cogent and he's saying that his family is lying to him and they decide to believe that 30-year-old man. But if there's a 75-year-old grandmother or something and the family is saying this happened and she's saying that didn't happen, the doctor in some sense has to decide who to believe when the stories aren't aligned. And it really opens and children are not another example where you might choose to believe parents. So it sort of like spotlights why there's so much variation in this admission process and what sort of patients we decide to believe and what sort of patients we don't believe.
I'll just add, I think it's very scary because this is a patient population where fundamentally their perception of reality is just discounted. And so it's just a lot of vulnerability. I mean, it's just, and I've been thinking about whether or not, how this is going to end up being weaponized in the United States politically against folks who dissent. And I think that we're kind of moving in that direction, and I hope we don't see that. But that's just something I've been thinking about. When we see Trump use words like they're crazy, he's already sort of laying the framework for being able to dismiss people and lock them away in other types of settings. Yeah.
Yeah, it's a really tricky issue. And I even as a clinician, you have to make these really difficult decisions under tremendous uncertainty. It's in an emergency context, it's hard to know what else, And so, for example, if a family member is saying that a suicidal threat was made or a suicidal attempt was made, and a person is denying, just an emergency clinician just they're not going to know what to do, and so and within in a short period of time, within hours, they have to make a decision regarding how to navigate the situation. And the way the incentives are in the system, most of them are going to lean towards erring on the side of caution, caution again, in the imminent sense, and trying to say, hey, let's keep this person for observation or admission further, and then after a day or two, things will get clearer. But I can't say it's been super common, but I do remember at least a handful of cases, even from my own experience of inpatient care, where this process was abused by the families, where families deliberately exaggerated or lied about something in order to get the person into the hospital. So there is this intentional weaponization. And then there's also this element of neglect and abandonment in certain cases too. It's unless you work in the in the mental health care system, it's hard to imagine. But there are families who will literally dump their family member in the emergency room and then just disappear. And like they're fed up with that person for whatever reason. They're unable to care for them, but they will just be like, we can't do anything. You figure something out now. And I feel terrible, for patients, who are in situations like that. And but yeah, it's a really difficult thing.
Yeah, I resonate with everything you're all saying. I spent 6 years leading a domestic violence program, and certainly saw weaponization of mental health systems used against survivors who then ultimately may have needed mental health services because of the abuse that happened. So it became like a self-fulfilling prophecy, and the abuse led them to becoming psychotic or experiencing other types of symptoms. I know we've only got 5 minutes left of time, so I really want to try and hit some of the big questions now. And this one, I think, it really underpins a lot of what we're saying, but it's looking at next steps. So, how do you all foresee that we can hold the system accountable, hospitals accountable, and change things for the better in regards to involuntary hospitalization?
I can go first just because this is what all of my research is about, is like thinking about accountability and what are those needed policies. And I actually don't have answers, but I have sort of a starting place, ideas for where we should start. So if we consider that inpatient psychiatry is the setting of extreme power imbalance, and we know that relationships are really important, and we have this concern for harms to people, then it would reason that there needs to be emphasis placed on patient-centered care principles. And that even, one might argue that, well, you can't have patient-centered care if you're going to force people into treatment. I would argue that it's a spectrum, and that we could try to maximize patient-centered care principles, but that there needs to be, that actually needs to be prioritized in terms of measurement, data infrastructure, financial incentives, et cetera, overall, but also specific to hospital care. There's just a lack of information in general. We don't know how common it is that people are restrained. Our national measures of restraint are pretty weak. These are basic information. We don't even know how common it is for people to be hospitalized on an involuntary basis. And so figuring out how to design the financial incentives to anchor around patient experience and patient-centered care principles as a way to try to address the fundamental power imbalance, I think, is where we need to move in directionally. It's just, how do we actually do that and operationalize that? And I'll just say that CMS has recently adopted a patient experience measure in their IPFQR program. And before this, psych patients were the only patients systematically excluded from patient experience measurement in the United States, which is discrimination, by the way. And so soon the data will be, well, we'll see, but we're hoping the data will be released, the first wave of data, next spring, 2026, I believe. Hospitals are voluntarily reporting, and then it'll be publicly reported. And so that's a good first step. But also what I'll say is, I think that there needs to be just a stronger emphasis on finding alternatives to the hospital, but we have to do both. Think about improving data and accountability and centering patient-centered care in hospitals, while also really meaningfully investing in alternative venues that might be best equipped to deliver patient-centered care than a hospital.
That's a absolutely great list of things. I think most of what I would do is piggyback on that list, just to highlight something that Dr. Shields said. The fact that we don't have data on involuntary commitments nationally is wild. Our best guess is this happens to 1 million people a year, which is a giant number of individuals. But the fact that we don't really know if that's true is, imagine if we did not know how many people were in prison, for example, in the state of Pennsylvania. I think we would be shocked by that. And then, beyond even the simple counts, exactly, restraints, what are the practices that are happening in hospitals? So as a data person, I've been very shocked to see how little data there is around on this. But then beyond that, I do work in the system in some sense. I'm at the county. So we are, a player in this. And I've been happy to see that locally, at least in the last year, there's been renewed animation around this, and things that we're trying to do are, really enhance the amount of care people have access to and the time after their 302, because we know that's an incredibly vulnerable time. We also know that's a time where their trust has been broken. And so what are the actual barriers to getting people into voluntary care? And we're starting to explore that, try to understand that. One experimental thing that we're doing is just offering financial incentives for folks to come into outpatient care after their inpatient care. We know that they need it. We know that if they don't get it, it's going to be bad for them and bad for the system. So let's try to be experimental here. What can we do that's voluntary that will get people again engaging with the system, along with the deeper work that we have to do to try to understand why people are falling out of that in the first place. So the list of things to do is probably long. I'm sure I've missed a lot of them, but we're hitting time, so maybe I can pass the mic to Dr. Aftab.
Yeah, I agree with everything. I think mandatory reporting of outcomes and mandatory kind of monitoring of patient satisfaction essential, and then investing in alternatives also very essential.
Wonderful. Well, this was a really enlightening, important conversation. Again, I want to express my thanks to all our panelists today. Round of applause to you all, but also a huge thanks to you, the people who are watching the webinar right now, engaging in the chat. I really appreciate all the passion and advocacy on this topic, and I have a lot of hope that together we can make that change. So once again, thank you all for being here, and I look forward to seeing you at the next ISPS-US event. Bye, everybody.
Thank you.
Bye.
See ya.
Bye.